My name is Clare O Donnell, and it's a great pleasure and honour for me to be talking to you from Auckland in New Zealand. And the talk today, as you will have seen, is on the late consequences of the Fontan circulation. Many of you will know that New Zealand is obviously a long way from India, way down here in the South Pacific, but one of the things about paediatric cardiology is that we do obviously share a lot of the same problems around the world. Just for you, those of you who don't know, we have this is me, and that slide is showing you that I'm sitting up in Auckland, which is up in the top of the North Island of New Zealand. We're obviously a much smaller country than India. The great thing for us here is we have the Starship Children's Hospital, which is actually joined on to that hospital you see down the bottom here. So this is Auckland City Hospital, and Starship is behind this. So I do a mix of paediatric cardiology and also quite a lot of adult congenital heart disease in the Auckland City Hospital. The Fontan population in New Zealand is growing. So these are patient numbers down the left-hand side, and you can sort of see over time here. We've been involved in the Australian-New Zealand Fontan study, so that's given us a very good handle on the numbers of Fontans. And if you see the age here, ages down this side, you can see that in fact this slide was made a couple of years ago, but we've now got people up to around 50 years of age who have had a Fontan. You will remember, though, that the Fontan has been a procedure that's been very much in evolution, and this is one of the diagrams from Dr. Park's book that I like that talks about the older styles of Fontans, where essentially we had a classic glen to the right pulmonary artery and then a Fontan which was just connecting the right atrium in a patient who had obviously they had also tried to they thought that you needed a valve also in this part of the circulation. So in this patient, the IVC right atrial flow is going to left pulmonary artery, and there's a glen going to the right lung. And then over time, people tried different arrangements of Fontans from these old atriopulmonary connections, coming to the more recent lateral tunnel with or without a fenestration. And then many places now would in fact perform an extracardiac Fontan, where a conduit is placed between the IVC and the underside of the RPA, and obviously we have the glen and anastomosis. Because the surgery has evolved and many other things have evolved, the whole population is not obviously identical over time, and so there are some people who have had a Fontan, particularly in my adult clinic, who had a Fontan well into their adult life. There are some people who've been staged through shunts and glens, and other people who were not staged. There are different styles of Fontans, as we just discussed. Some people had many years of severe cyanosis before they had their Fontan, and there are also other non-cardiac factors that come into the equation. So this is a population that it's important we study, but it's important also we keep studying because their problems are evolving. I'm going to talk today around Fontan failure, and that's obviously that term that we use, Fontan failure, a bit like heart failure, is kind of a loose term. It means that the physiology of the circulation is failing, but that can present in a lot of different ways. So we may find a patient who is unusually blue. We may find a patient who has important ventricular dysfunction, either because we see it on their echo or because they come in frank heart failure. We may have patients who fail because of difficult arrhythmias, protein-losing enteropathy, clots forming, ascites. I've got one adult lady at the moment who's in great difficulties with ascites, needing taps every couple of weeks. Or there may be combinations of symptoms and signs of failure. So when we say a Fontan is failing, we really need to define what we mean by failure. And we need to recognize that this process is often gradual and that there can be important cardiac and extracardiac features to the way that this failure can occur. The other thing that I'm really keen that we understand together is that in the Fontan population, we focus a lot on the heart, but there is a lot of multi-system disease. And so there may be congenital anomalies in these patients, cleft lip and palate, renal anomalies, anal anomalies, asplenia, other congenital problems. Or there may be problems that are acquired, and these might be related to the way the Fontan is working or not working, and I've listed some of those there. And then there might also be other acquired problems that are not necessarily related to the Fontan, but have a really important impact on how well the Fontan is going to function. So those are some of the acquired issues. This is from the Australian-New Zealand Fontan registry, and it was one of the earlier papers published in Circulation, where the publication was really about looking at long-term survival in this group. And you can see here that this population, at this point, they were looking at about 1,000 Fontan patients. The older ones here are the atriopulmonary Fontans, so 168 of those, and you can see they obviously start quite early on. And then as we get into later the end of the 1980s, we're starting to see some lateral tunnel Fontans, and the population is growing. And then we see the rise of the extracardiac Fontan in the Australia-New Zealand region. So that now if we look at the population, in fact, most patients in this area are extracardiacs, but a fair few still have lateral tunnels or the older style Fontans. This is from the same paper, and it looks at failure of the Fontan, and you can see in the bottom part of the slide there how that is defined over time, and it's looking at that by these different styles of Fontans. So you can see there that the longer dotted line, the one down the bottom there, is the atriopulmonary Fontans. Here are the lateral tunnels, and here are the extracardiac Fontans. And here are years since Fontan completion. So in this kind of curve, obviously, the oldest patients are the patients with the older style of Fontan. And so we're going to have a lot less data for these newer styles of Fontans. And you can see from this that certainly the lateral tunnels and the extracardiacs up to 15 years seem to be doing significantly better, although obviously we can't understand quite as well what happens out further on as the numbers become very small, as is shown below. One of the major problems, of course, is arrhythmia, and here is from the same paper the data in terms of rhythm problems, and obviously this kind of information has driven a lot of this development to lateral tunnel and extracardiac Fontan, trying to reduce the amount of scar in the atrium and reduce the burden of SVT over time, because you see here that these people who had the atriopulmonary Fontan, out at 25 years, many of them have had episodes of atrial arrhythmia, and that really is a major problem for them. This is freedom from adverse events in the group as a whole. So this is years from Fontan, and I put this up really because you can see the confidence limits grow a little bit over time, but obviously over time we are dealing with some of the atrial arrhythmia issues. But if you look across the board at 20 years, there obviously have been quite a number of adverse events in the population as a whole. And we'll talk a bit about some of those adverse events and what they are. But you can see here this, again, the same data broken down by late mortality and late failure, so not necessarily mortality. And you can see the risk factors for that, which include, not surprisingly, the older style Fontan, but also older age at Fontan, which is a risk factor for both failure and mortality. You can see that, in fact, the patients who stay in your hospital with prolonged pleural effusions are at risk for worse outcomes in the longer term. And obviously the hypoplas, who in many centres are becoming a bigger proportion of the Fontan group, are also at risk in terms of late failure of the Fontan. Interestingly, male sex also pops up as a risk factor. This is some data from Boston, from my former colleagues Mike Landsberg and Paul Carey, and they were looking at patients born before 1985 and the long-term outcomes of that group. And you can see they had 261 patients. If you follow this down, these were obviously early Fontans. So there's 76 that have died at this late follow-up, 5 have been transplanted, and 180 are alive with their Fontan. And if we look then at what's happened to those people alive with their Fontan, some people have had a Fontan conversion to a newer style or some kind of revision operation. If we look at the causes of death, which I think is one of the main things that's interesting here, there are obviously several different kinds of events. There can be sudden death, clot-related death, heart failure, sepsis, and other events that can overtake these patients later on in their follow-up. So I want to move from the mortality to talking a bit more about the morbidity. One of the major problems that we have is arrhythmia in this group of patients, and most of the time, in fact, we're dealing with atrial tachycardias, but we can also see bradyarrhythmias. The newer types of Fontan do seem to do better from this perspective, and we can see some ventricular arrhythmia. And as in many congenital heart groups, there is a risk of late sudden death. It's not high, but it is there. This is some of Barbara Deal's work, who's obviously a great authority, having done a lot of work in Chicago on Fontan revision with Dr. Mavroudis. And you can see here, this is atrial tachycardias in a Fontan population in follow-up. Early on, immediately post-surgery, there is a higher risk, and then things settle down. But you can see over time, the amount of arrhythmia is certainly growing, even over a period of 10 to 15 years of follow-up. This is that same data broken down by the type of Fontan. And again, as in the data that I showed you from Australia and New Zealand, it's the atriopulmonary group that have longer-term follow-up, but also seem to be not doing as well, with the lateral tunnels doing better, and the extracardiacs with shorter follow-up, but seem to be doing better at this early stage. This is again from Barbara Deal's paper, and I think it's an interesting breakdown of their approach in terms of people coming in with arrhythmia and trying to figure out the best pathway for these people. So she breaks this down into 4 groups. The group that has excellent hemodynamics, and you can see how they've sort of defined that group there, good exercise testing for a Fontan, and those type of patients, they would look potentially at either medical therapy and catheter ablation or potentially Fontan conversion with arrhythmia surgery if they're having recurrent problems or seem to be declining in functional status. There are patients who are clearly in more difficulty that they would put forward for Fontan conversion with arrhythmia surgery. There is a more severe group where they feel obviously that things have progressed too far, where they would consider heart transplant. But there are some patients, and we've all met these people, who really have multi-system problems, are not candidates for this pathway, and where you would need to think about some kind of more palliative medical therapy. This is data from the UK, again just showing you that these problems are not specific to any one place, again following up adult Fontan patients for different types of arrhythmia. And I guess the take-home from this slide is again finding that in adult life there is a high prevalence of tachyarrhythmias, even in sort of fairly young adult life. You can see here the age of onset in the different groups, and you can see some differences in terms of the style of Fontan, and numbers obviously lower in the newer styles, which give us a bit less in the way of predictive value. One of the other areas that I think it's really important that we bear in mind is that there are other factors apart from arrhythmia that may be affecting the exercise capacity of the Fontan population. One thing that's very interesting to me is that if you look at the exercise papers and look at patients from the adult congenital clinic, pretty much everybody you test in the adult congenital clinic who has any kind of cardiac abnormality, even if it's pretty minor, has a reduced VO2. Here is some data with regard to VO2 in the Fontan population. And this is a group of Fontans. You can see the numbers there. Obviously, over time, with pretty significantly reduced VO2 over a normal population. And there are a whole number of reasons for this, one of which was highlighted in this paper relates to lung function. But there are clearly a number of other factors involved. Here is the same data broken down, interestingly, by age at surgery, suggesting, although these are fairly wide confidence bars, but suggesting that those patients who had a younger age at surgery seem to be doing better in follow-up. If you look at the Fontan population, there are pretty consistent lung findings in terms of increased residual volume, decreased diffusion capacity in this population, and also restrictive lung function. And this is clearly contributing to some of the abnormality that we see with exercise. But undoubtedly, this is multifactorial. So we know there is an issue with preload in this population. We know that the cardiac output response to exercise is abnormal. And there are a number of other factors that come in here that are affecting exercise capacity, including, really importantly, the level of conditioning. And certainly I had an adult congenital clinic yesterday morning, and I had several Fontan patients, and we spend with our nursing team a lot of time talking to them about trying to encourage them to promote the health of their lungs and promote the health of their peripheral muscles. And conditioning is obviously really quite important in encouraging people to be as active as they can be. I'm moving on to protein-losing enteropathy, which fortunately we don't see all that much of, but it's a very worrying problem. It is definitely associated with poor hemodynamics, and so whenever we see it, we are looking for any factors that we might be able to optimize in terms of the Fontan circuit. But like any problem with multiple therapies, you can guess that it's unlikely that any one of these things is a panacea, although obviously the radical therapy of transplant has seen some success in this population. Certainly in our group, we would work our way along through these medical therapies, and we have had success at times with things like budesonide. We've certainly used sildenafil, but we, like many centres, would just work our way through any of the established therapies and just see if we can improve things from this perspective, Some of you may have seen some of the data coming out, particularly of Philadelphia, with people going in and trying to work on lymphatic vessels with catheters. We don't have the ability to do that here, but I think that's a very interesting approach. Clot. The incidence of clot in this population depends very much on how hard we look for it. And if you start to do more in the way of transesophageal echo imaging or more invasive imaging, you find more in the way of thrombus. There are risk factors for clot. Certainly being on no anticoagulation is a risk factor. There are definitely some well-documented coagulation factor abnormalities in this population. In these patients, as you know, the conduit and other parts of the heart may contain prosthetic material. If you have any stenosis in the pathway or out into the branch PAs, that's a risk factor. Atrial arrhythmia, PLE, high venous pressures are all important. What do we know? Well, we haven't been able to really separate out the particular benefit of aspirin versus warfarin. There are obviously institutional biases, but we do know that anticoagulation overall definitely decreases the incidence of clot in the heart. And there's good evidence from the Boston series and from other series that in long-term follow-up anticoagulation is important. We also know that in patients where we see thrombus, this is a marker for bad outcome. And you can look at data such as that from the Toronto series, which will show the interrelationship between the finding of clot and outcomes, including mortality. I'm going to spend a little bit of time on the liver because this is becoming increasingly important in the Fontan population. it's certainly something that when I was doing my fellowship, I don't remember us having any discussion particularly to do with liver in the way that we do now. And certainly with many of my patients, they find it somewhat upsetting when their main worry is about their heart and deterioration in their heart to start to learn that we're quite concerned about the growing problem with liver pathology in this group of patients. So one of the problems that we have is we're increasingly recognizing that quietly, without any symptoms, many of these patients are not only having congestion, but also fibrosis, in some patients cirrhosis, and there are certainly reports, as I'll show you, of hepatocellular carcinoma in this population. It's very clear that the longer you look from the Fontan, the more that you see these problems. What are we worried about? Well, as I said, what we're really concerned about is that somehow there seems to be this progression over time, very worryingly, we have a number of patients now who have cirrhosis and problems related to cirrhosis, as well as the cancer risk. This was one of the early papers to really highlight this. This is a very interesting case report published in 1983 from Michigan, and it was a case report of a woman who I think was about 8 when she had her Fontan, and she then went on to need a cholecystectomy, and at the time of the cholecystectomy they did a liver biopsy and uncovered liver fibrosis or cirrhosis on that liver biopsy. She had developed some stenosis in the conduit in the Fontan pathway, and that was dealt with at the age of 15 to try and improve her hemodynamics. More recently, so this is a paper from 1999 from the group in the Netherlands, Barbara Mulder's group, really showing that yes, you can document some abnormalities in liver function in the Fontan population over time. So these are obviously young adult patients. But one of the lessons about this is that really these enzyme abnormalities can be seen, but they're not all that common in this group, and they're not the best way to be following up in terms of liver-related morbidity. So you can see there are quite wide ranges, and in many patients, in fact, when you do standard liver function testing, the values may not be particularly abnormal. So this whole thing, and I'm just warning you that I don't have an answer to this, it is kind of a can of worms. We have a number of questions. When should we start looking for liver pathology in this population? How should we best screen for liver abnormalities? Who should we be referring for specialist review? Are there any ways that we can try and slow down these liver consequences or even prevent them? And what impact does this have on other interventions, including people's risk in terms of surgery, cardiac or non-cardiac surgery, and also transplantation? So Grushin-Veltman, who's now in Cincinnati, but he was working at this point with the Southampton group, and they looked at patients who they were considering for Fontan revision. You can see again young adult patients, and did a very thorough workup, including catheter and liver biopsy and CT, and really found that these abnormalities were very common. So of the 12 patients, cirrhosis was seen in 7. That they had some patients, in fact, who had varices and cirrhosis. And interestingly, if you looked at the hepatic vein and the wedge pressures, the transhepatic gradient, in fact, was pretty low. Abnormal liver function tests were seen in some, but not all. But certainly when you started to do CT scanning in terms of cross-sectional imaging, you found a number of patients had abnormalities, including these abnormal enhancements, collaterals, varices, big spleens, big livers, and these hypervascular nodules. And what they tried to do was, to use these findings as part of a risk stratification for Fontan conversion. When we talk about these vascular nodules, This was a further paper that looked more in more detail, a larger group, at the cardiac CT data. And this is the type of thing that they were seeing, these arterialized nodules within the liver in addition to areas of abnormal enhancement. This is a study, this is a paper particularly talking about the liver biopsy data and the abnormalities which particularly include this problem of sinusoidal fibrosis, but obviously some pretty profound abnormalities in terms of liver architecture in a pathological sense. The take-home messages from this paper related to the fact that that patients were developing liver fibrosis, and that this was particularly sinusoidal, and that they also saw dilated sinusoids. But there were some findings that suggested that at least some of this abnormality could be reversible. So that gave us some encouragement that if we start to see these things, any attempts to optimize hemodynamics or bring the pressure down might have some benefit in terms of slowing down progression. This is from our colleagues in Korea, again looking at quite a large group of Fontan patients in their practice at the end, really at the end of their adolescence, mean age of 19 years, and again finding large numbers with hepatic complications of different kinds you can see listed there, and certainly some associations with factors that might make us concerned that things are not working as well in terms of the Fontan as we would like. One of the clear findings in their work, and others have found this as well, is that the level of abnormality certainly increases as you get further out post your Fontan. And so obviously as these patients get older, we need to look more for these problems. We've talked a little bit about some of the pathological data. There is also some post-mortem data, and clearly the post-mortem data is obviously by nature, it is biased at being at the worst end of the spectrum, but people have described, again, the sinusoidal fibrosis, but also findings in keeping with portal fibrosis. There have been papers that demonstrate that whole spectrum of change that I talked about, right through to hepatocellular carcinoma. And interestingly, and I think I might have this on the next slide, but there has been a small amount of work that suggests that these changes may even precede the completion of the Fontan. Yeah, so this was one of the studies. This is a 2012 study in the surgical literature, but again, post-mortem study. Interestingly, quite an early age at Fontan in this study, in these patients who died, not a long time after their Fontan procedure, a lot of abnormality, but interestingly, some suggestion that in some of these patients who died early post-Fontan that the abnormalities in fact preceded the Fontan, which is very interesting. So why are we seeing these problems with the liver? Well, I'm not any expert on liver physiology, but there is certainly some data which might suggest why we have these kinds of problems. We know that in individuals who have a normal heart, that cardiac output to the liver is very important, and in fact that the liver soaks up a lot of your cardiac output, and that this occurs basically via the hepatic artery, which has some capacity to auto-regulate, and also there is quite a lot of supply through the portal vein, which doesn't auto-regulate. So you can speculate then that in the Fontan population, where the pressure in the IVC is higher, and so the pressure in the hepatic veins is higher, and also the liver is then exposed to the limitations in cardiac output in the Fontan, that perhaps the portal vein flow is diminished, and perhaps the blood in the portal vein is of lower saturation, and maybe we become much more reliant on the hepatic arterial autoregulation to try and cope with the demands of our liver in this setting. So there might be a number of reasons in this setting why the liver is more stressed. And then if we take into account that we have certain periods of time when these patients are more blue, they have low cardiac output, they have higher venous pressure, they have times when they're septic, that maybe these stresses in addition are leading on to some of these abnormalities which create the fibrosis and the other problems. This is a sort of schema for this type of thinking. And so obviously a single ventricle child going through maybe shunting, banding, Glenn operation, Fontan operation, all of these potential problems. And then risk factors for alcohol stress that we know of, for liver stress that we know of, that may or may not be in play in particularly our adult patients. There are some issues related to the way the actual heart is working, and then there might be other times, other ways that the liver injury itself is potentiated through various mechanisms, which leads us down the pathway to cirrhosis. This is obviously, these are obviously concepts that people are trying to think their way through, but we need a lot more data on this. So what do we actually do in practice? Well, there certainly are some non-invasive markers that are important. So thrombocytopenia is important, hyperbilirubinemia are important, and we certainly do biochemical liver screening and include a full blood count, look for these things. And in our practice, we are predominantly at this point using ultrasound to screen the liver, but there is undoubtedly a role for some of these other types of imaging, and there is some data that will come out shortly from the Fontan registry that hopefully will assist us a little bit with the role of FibroScan imaging. One of the problems with this is that my understanding of FibroScan is that it's difficult to tell fibrosis from congestion in the liver, and obviously these patients by nature of their circulation have quite a lot of liver congestion even at baseline. So like you, I'm waiting to see the data with regard to whether these kinds of approaches can help us. The role of biopsy also remains a bit controversial. One of the problems is that the cirrhosis itself can be patchy within the liver. And so therefore, if you're undertaking, for example, transjugular biopsy at the time of catheter, you can't necessarily be certain that the cause that you obtain are representative from all of the liver. So there are, I think there are pros and cons around biopsy. Other groups, and this is Fred Wu's work, this is the Boston group, so other groups have tried to look at other liver scores, and these certainly can be of some assistance in this population. This paper in particular, so you can see the MELD score particularly is based on your creatinine and your bilirubin, and you can see when they looked in a follow-up group of Fontan patients, looking at a composite endpoint that I think we'd agree would be bad outcomes from this population, there was some association with MELD score. So the best method of screening and the screening interval are unclear, but certainly what we are starting to do is from adolescence, we are starting to image the liver, and if we see abnormalities, we are referring these patients so that they're under a hepatologist. We're looking very clearly at how we can hemodynamically optimize them. And the rest of these, I think, remain questions for us all to try and figure out the best mode of management. Fontan conversion is obviously one potential for people with an older style of Fontan. And the largest experience of this, those of you who followed this literature will know that the Chicago group have given us a lot of data on their outcomes, obviously in a very good center with an established approach to Fontan conversion. The indications can be variable, and I've listed some of the indications that we would list there. There is some published data that from our region looking at the comparison of units across Australia and New Zealand. In New Zealand, we've had a reasonably aggressive approach to Fontan conversion and tended to feel that these patients with older style Fontans who are starting to develop atrial arrhythmia with great big dilated atria should be moved on to a newer style circulation. Some of the units in Australia have not moved as quickly on this, and I think the data would show that our patients have tended to do better over time, although obviously you could argue that if you take patients earlier, that obviously then over time you get a longer follow-up on that group just by nature of the age. But we would certainly be pretty convinced that you shouldn't leave the patients too long, because once they develop a lot of multi-system problems, they really become high-risk surgical candidates. Just a couple of other things I'm briefly going to mention, and then we'll have some time for questions. This is a study, again, from Boston, just reminding us to sort of think of these patients broadly. This was in relation to systemic veins in Fontan patients, and a study that really looked at chronic venous insufficiency in the adult Fontan population, and found that, in fact, many patients, many adults with a Fontan had venous insufficiency in their lower limbs. So you can see there the age of enrollment, which certainly wasn't terribly high. It's sort of early, perhaps in middle age. You can see these patients' age of surgical repair, and what they did was compare a tetralogy group with a Fontan group, both in terms of their types of surgery, but you can see there similar sorts of weights, perhaps slightly different in terms of numbers of catheterizations, and you can see compared to a healthy population, both groups had quite a high prevalence of symptomatic problems with venous insufficiency. Excuse me. And these are the kinds of problems which are obviously not trivial in terms of venous insufficiency in the lower limbs. And you can see there amongst the groups, when they tried to predict the patients with more severe problems, you can see the things that fell out again. Unfortunately, the men are doing worse. Older age was obviously an important risk factor. In terms of the Fontans, these older style Fontan patients, that was important. More catheterizations, and you will obviously be aware that over time, our ability to perk the lower limb veins without having to tie veins off or do cut downs has improved. But more catheterizations, more venous insufficiency, obviously some of these symptoms, and you wouldn't be too surprised that these patients who might have swelling in their lower limbs perhaps might need more diuretics. And some of these other things that would suggest that as a Fontan group they're not doing as well were also risks for severe venous insufficiency in the legs. So in summary, I think we can agree that we've got very good survival in the modern era for patients who've had a Fontan palliation, but this is very much an evolving story, and we need to keep looking at our patients, keep studying our patients, and recognizing that although they may have complex medical histories, that these are people with aspirations like our own to live in good health for as long as they can. There are a number of late consequences to the Fontan circulation of different kinds, and we need to be thinking not just about the cardiac side of this, but also about problems in other systems, how we can prevent them, how we look for them. And of course, if we're going to be caring for these patients, one of the really important things is these problems will become more common as the patients age. So we need to try and keep these people in follow-up. We need to make it as easy as we can for them to come to our clinics, and so that we and they together can help us learn how to look after these patients in the longer term. One of the things that I just remind you of is that, I find certainly the lessons I learn from these older Fontan patients really, really helpful when I'm talking to families about little ones that might have a Fontan, because I think it's really informs your way of talking and talking to them about how life might be, but also being hopeful that this is evolving and that things are continuing to improve. So I thank you very much for your attention. I'm very happy to take any questions.